All right, let's start there. Who's our repertoire?
Testing. All right, this is working. Okay, so we did get through all the questions, but we didn't get through all the questions, both at the same time. The first question was, which of the following tests or measurements would you implement at the end of TB treatment? So I think universally we agreed on symptoms because that's the most person-centered outcome, and that's what we felt was most important, and it's very individual as well. So one of the examples was someone who played soccer before they had their tuberculosis diagnosis, got treated, and now they can only walk. Yes, they can walk long distances, but they can't play soccer anymore. So that's symptoms and person-centeredness. The second thing, I'm actually giving you these in order of the second question, which is order of importance. It was symptoms and quality of life. Then the second one was functional assessments, but we didn't feel that just 6-minute walk test or sit to stand covered it all. Because, for instance, when you see someone getting their vital signs, measuring them and checking if they're hypoxemic, and then potentially exercising them, and then checking if they're hypoxemic again, and or checking for symptoms afterwards may be a little bit more sensitive. So we thought functional assessment, but with embellishment to the functional assessments. And then also thinking about anthropometrics, if we're thinking about children, are we thinking about their Z scores in terms of nutritional status, et cetera? So I think that was part of our functional assessments as well. We made it a little bit longer. And then finally, we said if someone has symptoms and or their functional assessment is abnormal, then potentially considering referring for something like chest imaging or chest X-ray. The reason we landed on chest X-ray more than the other imaging modalities, it sounded like, was really it's more universally available. The problem with chest X-ray would be the potential interpretation, and if you get a chest X-ray on everyone, including in some of the more remote areas where you have a nurse and a clinical officer taking care of the patient, the ease of interpretation isn't great. So we put it further down on our list. There was it depressed me. There was a lack of enthusiasm for spirometry. The question really was, is there capacity? Where can this be done? In our Kenyan context, it's really mainly in Nairobi. It's really mainly in private clinics. It's really mainly in research studies. So it's not really on our list. Okay, how many minutes do I have, Nilima?
2.
Okay, all right. And then which of the following factors did we prioritize? I think I talked about why we prioritize these things. Cost was a big one, but then person-centeredness was a big one also. Ease of interpretation. And then if we're talking about what do we want something that's reproducible and sensitive for the physiologic respiratory impairment or the impairment that the person has. And one of the quotes from our discussion was, we want something that can be done for everyone, everywhere, or for anyone, anywhere. That was one of our summary sentences. And then who, everyone, was our thought process, because if you try to delineate it by risk factors, it's difficult to then implement from a national TB program standpoint. Saying, oh, this person had extensive chest X-ray infiltrates potentially is important. However, it may be difficult to implement at like the more primary levels of healthcare. And then what concerns, much of the care is carried out in primary care facilities. It's not physicians, it's not centralized. So much of our care is in more remote areas and thinking about that. Programmatic levels, we've spoken about clinical and care perspective. We've spoken about really we want it to be person-centered and how symptomatic are they. And then research perspective was not discussed.
Amazing, wonderful. You've got a minute for any comments from your group. Anything else people want to add?
Yeah, so number 1 is symptoms, and number 2 was you examine, at least at a minimum, your vital signs and your anthropometry. So symptoms and then examination and key things that could be done even at the lower level. And then comes the functional assessment, like exercise test, 6-minute walk test, in that order. So that's column 1. because you wrote symptoms and quality of life. I was just trying to clarify that.
Yeah.
Yeah.
Does that reflect it better?
The first point was your symptoms, and you examine, and key things for examination, like your respiratory rate, your SpO2, your anthropometry.
Oh,
yeah.
so here.
Symptoms, examine, and then you can do an investigation if it's available.
My phone tells me you're done. All right, who's next? Great job, thank you. Brazil?
So Brazil, we've got 2 small groups, so it's 3 minutes each.
Okay. You're testing my PowerPoint skills here.
Okay, so I think like Jerry, we kind of finished everything but didn't. So I tried to summarize the discussion a bit. In regards to the first question, we agreed symptoms was sort of the primary one we could agree upon. Specifically, we talked about cough, shortness of breath, dyspnea. But I think another kind of interesting conversation was including symptoms that might raise the possibility of recurrent TB. So also making sure we asked about weight loss, night sweats, B symptoms. The second was imaging. And this also kind of goes in the order of importance in what we put. And chest x-ray is kind of all that would be available, so that's what we put there. And there was a spirited discussion about spirometry, which is not widely available in a lot of the clinics. But I think what we kind of landed on was that perhaps if we said it was necessary, it would drive a need for spirometry. And in the other questions, I'll kind of talk about why some of that was. When we thought about the factors that we prioritized, we talked about alignment with TB guidelines, cost, speed of completion, staff training requirements, access to equipment, kind of opposite what you would usually think, but driving access to equipment we feel was necessary. And then, we really felt symptoms were important for the sensitivity for physiological respiratory impairment. It was patient-centered, and that obviously is why we are supposed to be doing this. For question 4, we said patients who were determined to be treatment complete or cured is who we thought should probably receive screening as opposed to everyone, recognizing that may leave some who are getting unnecessary treatment still, but hopefully doing an assessment at the point at which we would hope that some pulmonary abnormalities would be clearing. The concerns, we talked about costs. One of the things that I thought was interesting that we ended up talking about was the treatability of some of the characteristics. So part of the reason for spirometry too was the hope that identifying, bronchodilation response or airway disease would actually lead us to be able to implement treatments, which we don't necessarily have a lot of for PTLD as a whole. The lack of existing technology versus requiring technology to drive capacity, we kind of mentioned that. And then, the other concern was implementing a PTLD screening while also assuring that there was treatment completion and a rule out of alternative diagnoses was something that continually came up in our group. 6, I'm sort of summarizing what we talked about to put these. We mainly didn't quite get there. But from a programmatic perspective, we felt that our screening questionnaire could increase an understanding of the burden of disease, provide need assessments for referral centers to pulmonary specialists in the health system. The clinical or care perspective, one aspect of a chest x-ray at completion would serve as a baseline for future care and symptoms. If you were able to then get an x-ray when someone had new symptoms, you could see if that was because there was really change on an x-ray and drive a search for diagnosis. And then from a research perspective, increasing our understanding of epidemiology, quality of life. And then I kind of summarized our treatability with a phenotype type discussion. Is this really mainly obstructive? Is this mainly destructed lung with restriction? Understanding some of the phenotypes of PTLD. So if there's comments, I'm sort of summarizing what other people said, but from the group. Anybody?
Great job. All right. Brazil group B, I guess. There's two, you said two groups?
Well, this is Brazil A. Well, I will just add to what the other group said,
Okay.
the things that are different. So on the first, we agree on symptoms and quality of life, and we would use the CAT questionnaire because it has a Portuguese version, and it was validated. So we thought that's important. On the image on the chest X-ray, we will take advantage of the use of AI to look at before and after, and kind of go over the limitation of training for X-ray reading. The factors that had influence on this scoring were mostly reproducibility of the method plus implementation. We left alignment to WHO or other types of alignment as the last factor. I'm trying to find here. Our main worries with this is on the cost. It's a huge burden on usual health. I mean, on low resources where you have like a few staff, less training, so it's a huge burden on staff, but also financially. And also we had like questions or concerns about loss to follow-up of patients, like starting treatment in one facility but ending in another facility, and then you don't have a way to have information before and information after on the same patient.
Any other additions to the Brazil group? You guys have a minute. Anything else from the Brazil group?
Just to mention, we mentioned AI there. I mean, this is not a paid announcement. I seem to be saying that more than once. But one of our sponsors is Delft Imaging, who have CAD for TB, and there are other ones, obviously. But that system is used, as you know, for diagnosis. There's no use of that system for PTLD or response to treatment. But potentially there could be. I mean, so I think, we've had some discussions, but if there's anyone that's interested in that, I think I'd encourage you to sort of pick that up. Yes, over here, the comment to that.
Yes. Thank you. Yeah, I'm from Delft Imaging.
Oh.
So can maybe shed also a little bit light on that from our side. So really trying to also investigate the use cases for X-ray for that case. And we really started working on that, but we could really use more clinical insight for sure. So yeah, started to work on that and see how we can also align it with clinicians to get the best implementable product out there, for sure.
Awesome. Great.
No,
You're going to have lots of people come up to you with questions.
But particularly as it was mentioned that like you can do the X-ray, but then if you don't have the interpretation, there's not enough radiologists. So it's, you do the test, but you need it interpreted. So.
Yeah. Awesome. All right. Who wants to go next? India, Vietnam?
Could go.
Vietnam?
Yeah.
All right. You're up.
So from the Vietnam group, as for our first question, we were looking at which of the following tests/measures would you implement as PTLD screening. So I think the one which was discussed the most was symptoms, specifically looking at things like cough, shortness of breath, wheeze, hemoptysis, etc. But then I think the consensus was also to possibly use like a standardized respiratory questionnaire. And I think the Group 2 Vietnam was considering MMRC as a standardized respiratory questionnaire to be implemented. And then when it came to imaging, that was actually our number 2 priority for a screening system. It was chest X-ray, which was considered because it was easily available. But then there were some concerns raised about interpretation and also whether we have access to baseline chest X-rays to compare the post-TB X-rays to. Finally, then we also talked about spirometry. This was number 3 on our priority list for a few reasons. One being the capacity, and also if people are trained on how to do spirometry, but also how to interpret spirometry. And also there were concerns raised about infection control as well when you do spirometry as well. So yeah, I think, and then functional assessment was also considered, but I think spirometry was what was finally decided as number 3 for us.
Okay. Awesome.
Great, so that was question number 2, yeah. And the main things that we considered when we prioritized them were implementation factors, so kind of cost, ease of interpretation, speed of completion, staff training requirements, and access to equipment, basically. Then coming up to question 4, I think the consensus again was everyone, especially if you're using symptoms as a primary screening method, then we should ideally try to screen everyone at the end of TB treatment. Yeah. For question 5, it was, so there were quite a few concerns about implementing PTLD screening at the end of TB treatment. Cost and capacity was number 1, talked about for all of the screening methods, but also things like education of staff and patients came up as an issue. Things like the stigma of having a chronic lung disease after TB was mentioned. And also there were some concerns about the current knowledge pool on PTLD screening and maybe also like lack of guidelines that's already available. Another thing that was mentioned from group 2 was also the continuity of care. Will it be continue to be taken care of by, will the patient be taken care of by TB physicians, or will it be different physicians or healthcare practitioners who will be taking care of these same survivors? Yep, and then when it comes to routine screening, and how will the data that we collect from this be used for these programmatic clinical and research perspectives. We kind of clumped them together, so I'll just go through all of them if that's okay. So from a point of resource allocation, I think the data collected would be quite beneficial. So for purpose of human resource and staff training, but also for resources for equipment and things like that. Also for advocacy, the data collected would be quite beneficial. From a clinical care perspective, maybe creating like a triage system for patients who need to be screened and followed up at different time points. And from a research perspective, to maybe able to characterize and describe the phenotypes of post-TB lung disease, maybe which we talked about a bit earlier with treatable traits and things, and also looking into the pathology of post-TB lung disease. I don't know if anyone in the group has anything else to add.
Yeah, you guys have another minute. Amazing.
Sorry, I sped through that one. Sorry.
No, that was great. Other comments or anything anyone else wants to say from the Vietnam group? Or any other groups? Any other comments? All right. Zambia?
Thank you. I'll start off by saying that we also didn't quite finish everything, but we had quite a lot of robust discussion about the TB program. So in terms of the first question, we prioritized symptoms, I think like everybody else. We discussed things like cough, shortness of breath, and there was also quite a lot of discussion about whatever questions we use should be fairly short, no more than 5 questions so that they're implementable, with that in consideration. The next on our priority list was functional assessments. And here we also had some debate about what functional assessments to use. We discussed the use of questionnaires, and that whatever questionnaire should be used should actually be relatively short so that it's possible to implement it at all levels of care, especially considering that the majority or bulk of patients are seen at primary care, most by a nurse, and at best, next level, a clinical officer. There was a huge agreement that we would not recommend the MMRC. It's too long, and St. George's questionnaire. Sorry, it's too long, really that was discouraged. That we shouldn't use questionnaires that are too cumbersome, especially at the primary care level. And then next we prioritized was imaging, and chest X-ray came up as the one that would be implementable at all levels of care, perhaps barring the primary care level. And I think in difference to other groups, we also had quite a discussion about whether whatever screening should be happening should be different at different levels of care, considering the equipment needs, the prioritizations, the level of expertise at different levels of care. That was something that was actually brought up by a group which was different. And then going into question in terms of implementation factors. A lot of issues were mentioned around staffing, costs of equipment like spirometry, which would not be implementable in Zambia because for a country of 20 million, there's only 16 spirometers. And also issues around access to actually quite a lot of discussion around costs, not only to the healthcare systems, but to individuals having to be escalated across the route of the chain of level of care with regards to having access to specialized testing. And then about question number 5, which patients? We had some concerns in terms of how patients would be identified. We all agreed that people who completed treatment or were cured should be tested, but there needs to be some specificity about who is identified as requiring assessment for PTLD, whether it's people with new symptoms or those who have not improved despite treatment. And then finally, the last question, we didn't quite complete all the answers, but we thought that routine screening data would be very useful for research to generate some pilot data, even small, to generate more funding to research PTLD. And from a programmatic perspective, there was quite a lot of concern about whatever is implemented should be implementable at the primary care, at the most basic level of care. Gunnar, anything from the group?
I think that's fine. One point we raised at the very end is that we should look really with all that, looking at PTLD, at respiratory health in general, also, and use this opportunity to have a broader view on respiratory diseases and where we know so little about in many of the contexts we work.
Just one more thing to add. We did a quick check of the number of pulmonologists in the different countries that were represented. Mm-hmm. It's quite striking. It's a very rare species in some settings.
That's what we like to
So
think
I think we need to move from physiology to pulmonology itself. In some countries, basic capacity building is needed.
Yeah. That's a great point. Oops. Okay, amazing, thank you. I hope my notes are capturing this so someone can correct me. All right, last but not least, India. Can we get a microphone that way? Thank you.
So it was very interesting discussion. Actually, 3 groups, they had a lot of debate, but all of them, they agreed on symptoms first, chest X-ray, imaging, and then functional assessment. But one group strongly felt that chest X-ray should be done first.
Sorry. You have time. Go ahead.
Yeah. So the reason for going for chest X-ray first is since program is routinely using it at treatment initiation or diagnosis as well as end of treatment. So you will have a longitudinal comparison, and even after treatment completion, if patients comes back at say 9 months or 12 months, you can correlate the changes. So that way, they feel that chest X-ray will be the first priority. But at the same time, this group also felt that BMI should be considered because in Indian setting, the correlation of BMI with other morbidity as well as mortality, it is showing the association. So I think that can be considered. But overall, it seems symptoms, chest X-ray or imaging and functional assessment. Yeah, and the factors for question 3, as I mentioned, longitudinal correlation in case of imaging, but at the same time for other cost, ease of implementation, that was the major concern for choosing symptoms as well as functional assessment. For question number 4, everyone, they agreed that everyone should be screened. And for question 5, concerns regarding implementing this PTLD screening. So the first, in terms of X-rays, they mentioned that pathways to care is the key thing, because nobody, in our group, they mentioned spirometry or point of care spirometry. The reason is, if you are investing that much and if you don't have a referral system in place, then it will be challenging. Means in vertical disease control program, there are always limitation. Integrating the services with other expertise like pulmonary medicine or other things, it is challenging. So that's why spirometry was not mentioned. And for question 6, I think from programmatic perspective, they think for program it will be, since they are doing a lot of things, they have digital platform for tracking patient level data, so it will be easy for them to assess the lung abnormalities among TB patients. And for clinical or care perspective, it will help the program to prioritize which patients they can focus. And from research perspective, I think the main thing is the burden of PTLD among TB patients. Anyone from group want to add something?
Amazing. All right. Oh.
Yeah.
Yeah.
No, one small concern we had discussed was lack of registers cause any scalability of TB interventions. For example, we have registers for presumptive patients, registers for treatment, but at treatment completion, if we ask all these symptoms and we don't have a designated end of treatment register from which we can say this one we saw in 2019, can we give them a call in 2020 something? So we felt that lack of a current register in the care continuum should affect scalability of anything we screen at the end of treatment. Over.
Amazing. All right. Well, thank you all for your amazing participation and feedback. Any other comments or about sort of priority factors and the things that you thought about before we sort of switch gears to our panel discussion? Yes, please. Yeah. So the comment was, I don't know if everyone could hear that, was that given the lack of availability of spirometers and training, could point of care peak flows be an entry screening or sort of a screening assessment?
Okay, my question is, among the 5 countries, do we have any country which experience cross-border and artisanal mining? Because those 2 scenarios brings a lot of other issues in terms of follow-up and even on data and so forth. If we have any country which experience TB mining through artisanal miners or cross-border issues, like Southern Africa, where people cross up and down the countries and so forth, then if we have that country, I think I would like to see how we can also factor in to take care of PTLD in those scenarios. Thank you.
Yeah, thank you. All right. Should we wrap it up and we'll move on to the panel discussion? Sorry? Yeah? Oh, sorry. And we'll have a few minutes with the panel discussion for questions as well. Thank you. That's a great point. All right, if we could have Dr. Chikaya, Dr. Celso-Costa, and Intan Dewe come up to our illustrious panel here. Jamila is going to facilitate the panel discussion.
Thanks.
Yeah, of course. You want me to lead this out?
Yeah. So I know there are still some questions in the room, so hopefully we'll have a few minutes at the end just for a few more questions. My name is Jamila Megji. I'm a respiratory clinician from the UK, and it's my pleasure just to introduce our three colleagues here who are going to help us to think through some of the questions that arise from what we've discussed. So firstly, I'd like to introduce Prof. Jeremiah Chikaya, who's a respiratory clinician from Kenya, past president of the union, previously led the NTP program in Kenya, and has done a lot of work with the Stop TP Partnership, WHO, etc., at a policy level. We then have Dr. Celso Costa, who joins us from Mozambique. And Celso works at the National Institute of Health. He leads CISPOC in Mozambique, which is a research institute. And he's had lots of research experience in TB, HIV, other comorbidities across the clinical and kind of public health space. And then we've got Intan Dewe from Indonesia, who's a Wellcome-funded fellow who is setting up a really fantastic cohort of TB survivors in Indonesia looking at long-term outcomes. So we've got a lot of experience from kind of research, implementation, policy perspectives here. So I'm going to start off with a couple of questions just to the panel, and I'd encourage you just to have a think about any questions that you might want to add or ask or raise. So I guess my first question, everybody's poised with a pen, ready to go. The first question for the panel, I guess, and it's been touched on from colleagues from India in particular, is we all know that access to kind of respiratory care in many low-income settings is limited, right? We don't have much resource for care. So in that context, how do we feel about screening for post-TB lung disease? Is that problematic? Should we still be doing it? What are your thoughts on that? Celso, maybe I could start with you. You were looking straight at me, so you go first.
For example, I will take the example of Mozambique. Respiratory services are available at secondary and tertiary levels, while TB treatment is done at the primary level. So you have a gap here. And many times, people with TB would have access to service only on primary healthcare, not being able, for example, to go to secondary healthcare where they would have x-rays, or tertiary healthcare where they would have CT scans. So basically, there's a gap in the continuum of care. I do think we still should assess for PTLD. That would allow us to gather data at this initial stage. And with this data, we could implement or foment a change in how the TB service or TB care is organized. Because I think, for example, for many countries, TB care is still the kind of the old concept where you have TB, you are diagnosed, you have your treatment, and you're cured. And that also happens on the level of data collection. For example, many times when I have a patient, I'm not able to go to the previous TB episode to check what were the culture results, what was the smear result, what were the symptoms. So I have to trust the patient on what he remembers about his disease in the past. So I would say yes, and I would say that that will help us to change a little bit this kind of vertical way that the TB care is designed.
Thanks, Celso.
I don't think there's anyone in this room today who would still question why we should do this work. The clinicians know very well that you treat people very well for TB. you cure them microbiologically for TB, but a lot of them continue to have problems. And you want to know who has problems, and you want to offer care so that you can offer holistic care to people who have TB. Now, that holistic care might mean a lot of things. It might mean taking care of the alcohol use disorder problems. It might mean taking care of their, social protection needs, like we were told this. But the basic thing is to know whether their health, at the end of the day, lung health, has been affected by the TB problem. Everyone these days is talking about patient-centered care. You cannot talk about patient-centered care when you leave me with a disease that is untreated just because you've taken care of me microbiologically. I think it's obvious that no one in this room would question that. And I think also, if that is a message that goes out there to people in ministries of health and ministers of health and those who fund health, it is obvious that you can get traction talking about providing holistic care to people who have had TB. I think the why, the how, we have just discussed that, the how, and I think maybe for me, the issue, especially for public health programming, is if I'm going to do something for these individuals, I want it recorded and I want it reported so that eventually I can say, as a TB program manager, we had so many people that we screened, this is what we found, this is what we offered, and these are the outcomes that we are seeing. So that then my minister can say, you're doing a good job and I'm going to continue to give you money to do what you're doing. Thank you.
Thank you. So maybe I can say this based on our experience. So we are currently, Indonesia is ranked 2. So that's a great achievement. We're ranked 2 in TB. I hope we don't become the champion. But so I think it is really, all of us here agreed that I think we need to implement. But I don't think people in the ministry, at least in our country, they are still focused on improving the detection rates. So diagnostics and case finding is still the priority. And I think what is important is that, yes, it is important to screen everyone for PTLD, but what is important at the moment is to collect data, at least to show them the burden. And because I think we discussed this also, that there are currently no burden of how big the PTLD is exactly. So I think we should start before we should implement, and I think we all agree that we establish the burden of PTLD itself. And I think it's actually something that we could already do based on the current registry. For instance, we discussed about this in actually have data from the presumptive TB cases with previous history of TB. There are numbers from these patients who have negative bacteriology. From there, we can actually already assume portion for PTLD, for instance. And I think that's the urgency, at least in settings, high TB burden settings like Indonesia, that we need to really establish the burden. Yeah.
Yeah, great. Thanks. So it sounds like some consensus around defining the burden of disease and maybe also changing the way we structure and think about our tests. That's really helpful. We're going to try and find the other mic, just because that one's cutting out a bit. But whilst we're doing that, maybe I could ask a sort of a follow-up question. So if we think that we should be screening for post-TB lung disease at TB treatment completion, if we take that as assumed, we've talked a little bit today in our groups around what screening tools we use, how we do it, and there's obviously been lots of discussions and lots of different perspectives from people in the room. I'd be interested to hear, do you think that we should standardize our approaches to screening for post-TB lung disease across different countries, across different settings? Or is this something that individual countries should be able to decide for themselves, their individual approaches? Who wants to go? Chakaya. Ready.
From a clinical perspective, I would say don't standardize. But that becomes impossible to implement from a public health perspective. If you want to offer care with a public health approach, and we have seen this happen with antiretroviral treatment programs in Africa, for example, standardization helped. And standardization has helped with our TB programs. And I think we have to continue standardizing care for a program like a PTLD, care and treatment program. If we standardize, we know we will miss out some people. We know that our standard approach will not be able to benefit some people because not everyone can be put into that box. But if we think carefully about what that standardization would mean, we can come up with ways in which we can probably meet the needs of more than 90–95% of our patients. The 5% who will not be, we won't be able, through our standardization approaches, we won't be able to have their lung health needs met, can be, you know, there are referral systems that if we put referral systems that are very good, eventually this individual can reach the topmost pulmonologist in the country who can take care of those rare things that most people may not be able to do. So for me, I think, yes, it sounds like if you standardize, you're putting everyone, you're saying one size fits all, but if you carefully think through the common problems that people have and the way they present and the care that they need, you can come up with a care package that meets the needs of most people with post-TB lung disease, knowing that there will be a few people who will be out of that net, but you can create mechanisms for the needs of those people also to be met.
Intern, go ahead.
Thank you. Yeah, I agree. Actually, maybe in general, standardizing is good because at some part the data can also be shared and you can really see common characteristics, and also that would help in policy. But what is important is, I think, we should also highlight the specific demographics for TB. We discussed this yesterday. For instance, like in Indonesia, TB HIV comorbidity is less than 5%, whereas TB diabetes is 25 to 30%. And these patients are the categories that might have a higher risk for post-TB cardiovascular disease sequelae. So I think apart from standardizing the post-TB package, I think in these specific populations, I think they are the ones that we should look at. For instance, in Indonesia now, in all TB patients, they have randomized blood glucose testing, and then in high glucose patients, then they get HbA1c measurement, etc. And I think these kind of things should also be considered.
So standardization with some flexibility.
I don't have a lot to add, but I completely agree. There is not one size fits all. I think we should work on a toolbox where the countries can go and choose the tools that would benefit the country. In countries that you also have high burden HIV or even high burden, high blood pressure, different tools might be needed. And I think we should try always to verticalize, in the sense that if you could connect this to a program like non-communicable disease program, this would help the continuum of care, because then we could use the other stuff, but the other tools that are used to follow people for longer, that's different in the, I would say, TB care at this moment.
I'm going to open it to the floor. I think we have time. Any comments or questions for the panelists from the floor? Yes.
Yeah. So I think there is a tension, I think, in the subject. The one is called medical approach, which I think is where it started. We need to define a syndrome. We need to define its phenotypes, and then we need to go look for the pathology and the optimal treatment package. Now, I can understand that coming from the medical base, but we had a session this morning on social protection, which is on a very different route.
And we've heard from our colleague, Professor Mua, talking about a care package. So you could imagine for people, even those who have post-TB lung symptoms, the biggest problem is caring for their family or fighting their alcoholism or their depression. I don't think it's soluble really to collapse one into the other. I think we must recognize it as a tension or dialectic. So I think we could probably only go so far, given that we haven't got that many treatable options for the medical system. We must pursue that. But I think the more social public framing is very important. And I think from the type of case studies we're hearing, some of it is not really about treatment by doctors. Mm-hmm. It's about what we heard this morning as social protection. Thanks.
Thank you. That's a really important point. Thanks for that. Brian, can you yell, Brian? Oh, but there's another mic here, yeah?
Thanks, guys, and thank all the efforts you guys have put into this. I think it's a very, very important topic. There is a tension and a conflict, picking up on your first question, Jamila, that we need to deal with as a community. If you think what screening programs are, and let's use the cancer example, you find once you've diagnosed a cancer, you find a treatment, and when the treatment is effective, then you go back and work out the screening program. And the WHO clearly states that once you've done a screening program, you must have quick access to treatment, effective treatment. And I think what we're doing is we're doing it the other way around. And we need to realize we're doing it the other way around. Because we've got to be real. We don't have a lot of dedicated post-TB treatments yet. I know they're going to come. They're definitely going to come. And yes, we've got the respiratory care package where we've got the vaccination, the health, all the cofactors. I don't argue that at all. But we've got to deal with this tension, because in every country where TB is a major problem, there's a finite budget. And if we are advocating for something, we're taking away from something else. So we're taking away from mother to child, etc., for screening programs. That's not to say we shouldn't do it. I'm just saying we need to deal with the tension. And I loved your comments about assessing the effect, using it to do two things. To assess the effectiveness of an NTP program, I think, is very important, because we know that if you can reduce your spirometric deficits, if there's less abnormality in the TB care, you've probably got a good TB program, because you're identifying things fast and you're treating them fast. I think that's the first thing. But I think your point about advocacy is very, very important. The difference between post-TB lung disease and all the other cancers and stuff is that it's a disease of poor people. And because it's a disease of poor people, nobody's aware of it. And by screening, you're actually making people aware of it. And then suddenly there's going to be this massive burden of disease, which everybody's like, oh my word, there's this burden of disease. And then the treatments hopefully will be fairly short after that. So I'm kind of arguing against myself, but we do need to deal with that tension, that we actually don't have one of the tenets of a screening program, that it's effective treatment for the disease itself.
Thanks, Brian. Does anyone from the panel want to comment on either of those 2 points? This sort of tension, I guess two tensions between the sort of clinical and the social context, and then the screening without treatment.
I know people in the room here who are very good clinicians and are also very good public health practitioners. And I'm not saying I'm a good clinician, but I'm very interested in being a good clinician and a good public health practitioner. At the end of the day, it is what kind of care is given to individuals. And if that care is given to, if the care that you're giving as a pulmonologist is what is being given to the majority of people, then you are a successful clinician. If you are the only one providing high quality care and everyone else is getting poor quality care, you're a bad clinician, in my view. So I think the interactions between the medical world and all these other programs need to be aware of this. If you're running your TB program today, you need to be able to know who is offering nutritional services out there, who is offering social protection programs out there, and you link your patients or your people with the disease appropriately to those. Now, those are difficult things to do, but it's the programs want to do the simple things, go into the community, screen people for TB, and then give them treatment and tell them, bye-bye, you're good. That's the simple thing to do. A good program now would know that these are the guys who are giving social protection, these are the fellows who are doing nutritional support, and if I have If I have somebody who needs nutritional support, that's where they go. I think that to me is good public health, and that's what we should be advocating for. And I think our screening programs should also be pegged on, more or less like screening tests, there should be target product profiles for screening for PTLD. We need to adopt a screening program that gets most people with that disease. High sensitivity, our tool should have a very high sensitivity for picking up people with PTLD. If we use spirometry, for example, I mean, we all know there's a disconnect sometimes between what you see on the X-ray and what the lung function test is. And there is a disconnect between what you see on the X-ray and the symptoms that the fellow has. So we need to be able to decide what is it that we are looking for when we develop a screening program, so that we get to the people who really require care now and the people who are likely to require care tomorrow. I think that's very important for me.
Thanks, Chifai. Interns also, any other comments on that?
Maybe add that I think we need to be careful to have equitable post-TB care, in the sense that we need to make sure that, I mean, if we develop tools that can be used in low resources and high burden, because most of the people that suffer from TB don't reach the higher levels of care. So they need to have access at primary health care, but they also need to have access to all these other social, psychosocial, and financial package that can support them, because I imagine, and part of the studies show this, that those patients will also have high impact in these areas. So I think that's really important.
So I'm going to take two more, we've got 4 minutes left, so I'm actually going to take 3 more comments, and then we'll put it to the panel, and then that might be enough. Many questions coming. Go ahead.
All right. Thank you to the panelists and all the discussion that have gone on so far. Since we're about advocacy, I just wanted to draw attention about the fact that we have always been discussing about post-TB lung disease diagnostics using the current status quo, the same treatment that is being used throughout the world, generating this excessive number of post-TB lung disease that we are still trying to understand. I think we also should be advocating on new treatment for TB, because what we are describing is a consequence also of what we are currently treating. During the expose, I did not really see emphasis on how could we make the current treatment better. Again, the area of host-directed therapeutics, we know that we'll be discussing about it in the subsequent session tomorrow and day after, but I just wanted to highlight that point, that we're dealing with a problem that will contribute to generate, and we should also be investing in how do we resolve that upfront rather than downstream. Thank you.
That's a point well taken. Mateo's behind you.
Thank you. I'll probably expand more from what Brian said and part of what Professor Chakaya has mentioned on we cannot understate the social impacts of PTLD and just other diseases. Like also I think says post-TB lung disease is a disease of the poor. It's important we're coming up with or thinking about screening tools that are appropriate for different levels of care. But you screen me positive, I need perhaps to go to the next level of care. How do I get there? If I save funds. So that's a socioeconomic aspect. I have back home a ward full of post-TB lung disease with hypoxia due to either pulmonary hypertension or severe and extensive fibrosis. And they're in hospital for oxygen. And they can't go home on portable oxygen because it's not available. They'll need to fund. For those that have maybe portable oxygen in form of a plug-in oxygen concentrator, right now I do not know here in South Africa how the level of load shedding is. But back home in Zambia, I have a patient who had a plug-in oxygen concentrator at home, and because of load shedding, could not use it at home, so they had to come back into hospital. So in terms of hospital, hospice care, aftercare, those in most African countries have to be self-funded by patients, most of whom are poor. So I think we have to talk about a lot of those. That's point number one. Then number two, I think we discussed in the group the issue of not just post-TB lung disease, but comprehensive lung care, chronic lung disease. Because some of these patients, it's easy to attribute, whether they've had previous TB or not, to attribute to post-TB lung disease, because there's always a thing of fads, I think, in healthcare, from a public health perspective. By fads, I mean one moment we all talk about COVID, then it dies out. Within another, we talk about asthma and COPD, then it dies. And the next we talk about PTLD, and then it dies. Of course, these all continue, but I think we need a comprehensive lung care. There's a small study we're doing looking at enhanced diagnostics for patients who are meant to start presumptive TB. And then we say, okay, don't start presumptive TB. Let's have an enhanced diagnostic workup. And we haven't yet published, we're still ongoing, but from what we're looking at, there's so many things that, in terms of diagnostics, it could be CTD ILD, it could be other ILD that are coming out in terms of diagnostics. So I think it's important to look at lung health comprehensively. I think without taking much of your time, I'll end there. Thanks.
That's perfect, Matteo, really helpful. So this idea of it being broader than just post-TB lung disease. There's one comment here which we'll take, and then I'll ask you guys to respond. Thank you.
So, DJ Christopher from India.
Oh, wonderful.
So I'm finally here after
Thank you for joining us.
Nightmare of a trip. So what I'm going to see may slightly jar with what is said. Someone called me a rare species in the room. I just want to say that I think we have underplayed the role of spirometry. Now, all the other things that require evaluation by X-ray would anyway get done. If a patient comes back with symptoms of bronchiectasis, we are going to get a chest X-ray done. If a patient has had pleural effusion, follow-up would require a chest X-ray. So where required X-ray is always going to be done. But the one thing that may unearth a lot of damage that has happened is spirometry. Now, all the studies that highlighted the damage to the lung from TB is spirometric and walk test, the parameters. So really, I think we should not dismiss an important tool because it's not easy to get. Let me take the analogy of COPD. Like COPD is another very common problem. Nobody diagnoses COPD with peak flow meter. They say spirometry is the gold standard. And when you advocate good standards, people rise up and spirometry purchases increase, they are more widely available. Now, spirometry is not a specialist tool, it's actually a primary care tool. It should be used by anybody treating asthma and COPD. So I think spirometry is something that, while I understand, we need to be pragmatic about things and we need to understand the challenges, but we need to set a good standard. Some may achieve it today, some may achieve it later. Let me just close with one analogy. Now, did you imagine that TB will be diagnosed with a molecular point of PCR test only 15 years ago? We didn't, but that's the standard of care. And it's advocated to be offered to every suspect. Thank you.
Thank you. So I'm going to ask each of you just to kind of respond to those three comments and just final wrap-up words. Go ahead.
So I will maybe comment on the first part. I think I agree with you that I think thinking about therapy, new therapy options is important. But I think the challenge in, you mentioned about HDT also is what outcomes are we looking at? It's like, it's relevant, like are we looking at lung function? Are we looking at inflammation? I think that's one thing that we also need to highlight, and we can discuss this further on the workshop on the management. I think that's one part that we're going to discuss. But I think if we wanted to also think about this, then we should really highlight what kind of outcomes we wanted to look at.
I think all the comments that came through are wonderful comments. Comprehensive lung health is what we should, I think, all be going out for. If there was a treatment that we could give people with TB to prevent them from getting post-TB lung disease, that would be wonderful. I mean, one of the things that I'm hoping this group eventually will work on is predictors of PTLD. If we can, from the time into the healthcare system with TB, somebody can look at me, carry out a test or two, say this has an odds ratio of or risk ratio or whatever of developing PTLD, and this treatment might work to help him not get PTLD, that would be great. We are very far from there, but I think that's where we should go. I love spirometry like all of us. but I sit in the board of GINA, and I realize that even in places where you call high income, that thing is still not that easily available. And it's also a difficult test to do. It takes Lindsay 20 or so man-hours to train people how to do good spirometric lung function testing. I wish there was a test that we could do, like in many other things, a blood test or a urine test or a stool test that says, hey, if this is positive, this guy has this form of post-TB lung disease. That would be great. Rather than pushing spirometry, I'm pushing it, but I'm talking to people who I believe know spirometry. We are not talking about people who might say, now that he has said that, we won't buy it. Please, let's go ahead and push for spirometry to become available. But we all understand that this tool is not the easiest of tools to do, even after training. Quality of spirometry that comes out is still in some places very poor. And the more spirometry you have, the worse, I think, the proportion of spirometry that might be poorly done might increase. I wish we had a different test for asthma, COPD, and all those, maybe a blood test. It's the same thing with inhaled medicine. The clinicians that are here know it. You train people on how to inhale their meter-dose inhaler. 3 months later, you tell them, show me how you do it, and they're doing completely different things. We wish there was a tablet or something that they could use to get these things so that we get rid of these inhalers if we were able to, but we are not, unfortunately. So we have to learn how to do spirometry well and teach our people how to use meter-dose inhalers and all those other gadgets that are not very good, but we must teach them how to do it well. I think this is the reality of where we are at this moment in time. Thank you.
Okay, thank you. So I hope I don't get in a political situation, but I think we will make mistakes and we will correct those mistakes. So basically, I think that there is a role of operational and implementation research, and maybe we should involve the different NTPs in this, seeking this evidence about endotypes, evidence about phenotypes. I think we can maybe with AI improve spirometry in the sense that if we have better algorithms on the device and smaller device, and maybe cheaper device, because if you look now before Gene Expert, no one would imagine that now we have like a $10 test. So maybe that's something that we can do with the spirometry in the sense that we can try to improve and develop new spirometers.
Thank you. Okay, can I just ask for a vote of thanks, a round of applause for our panelists? Thank you. Lots of food for thought, lots more questions in the audience. Don't run away yet because we want to ask for your thoughts with another QR code.
Okay, it's our group's favorite thing. So there's a QR code. Your small group facilitators have a QR code as well. Oops, sorry. Okay. The purpose of this is to get your individual level perspective. So you'll recognize the questions from our small group discussions, but we really want to get some individual level information about sort of what you think about doing end of treatment screening and assessments, what those should be, some of the priority factors. The other really important thing is that we want to continue this work after the symposium and continue to have this discussion and build on this discussion. And so what we're asking for at the end of that form is that if you're interested in continuing, which will mean probably meeting with a group of us regularly over the coming months to sort of further discuss this and think about sort of ways to move some of these ideas forward. Well, we're asking for your name and email address, so please include that. And if for some reason you can't access the form or have any issues or undecided about participating but want to participate, please come find me and I'll take your name and email as well. All right, 4:20. All right, so we've got a little break time, so you can go out and use the restroom, get some water, stretch your legs, and then please be back in this room at 4:20. All right, thank you, everyone. Thank you so much to our small